Let me hit record really quick. So let me begin by just thanking everyone that could come on such short notice for being here, really to talk about and to answer any questions, comments, or thoughts around the college's COVID response at this point. I will say that now that we are in, I think, year 2 of this, our insights are a little different than they were this time last year. I am joined by President Byerly, who is going to bring some remarks, and then Ben Miller, who I will leave it to him to provide some fine introductions, who has been our consulting epidemiologist during this time period. And so, President Byerly, I'm just wondering if you have a couple of thoughts, and then I'll turn it to Ben, and then we will take some questions. We already have some questions that folks have already submitted, but we will officially take some additional questions as well. So, President Byerly.
Thank you. Thanks very much, and thanks everyone for taking the time to join us. We know that we've put out lots of memos. We've had some communications go out in the past, but there's so much going on and things change so quickly that it's hard sometimes for people to feel like all their questions have been answered. And so we hope that this will be helpful. I just want to thank everyone for their patience and their commitment to making this work in spite of the things that are challenging at this point in the year. I think we all hoped at the end of fall that we would be looking towards a bit of a smoother stretch at this moment in time, but I think people are managing circumstances that are very challenging, as best they can, and really with a lot of fortitude, which is much appreciated. One of the things that I wanted to mention is that I hope that you're certainly finding that in working with the faculty and staff, who you're most closely connected with, I hope you're finding that people are, trying to be flexible and adaptable, where necessary, but also recognizing that we're moving into a period where trying to get things on a sort of regularized schedule is also important. And so we're trying to balance flexibility with the need for some routine and structure. And sometimes we get it right, sometimes it's a little challenging. But I think that what I've heard from faculty in particular is that they are very appreciative of the fact that students are being very good about following our protocols. Students are being very patient about the adaptations that are necessary as folks move in and out of isolation. Faculty, of course, has had to do lots of sort of shifting and adapting themselves. I've heard many talk about, being about to walk into class and then getting a text saying 2 students will be missing and having to figure out how to accommodate that. So they're absolutely, working hard and doing the best they can. And I've heard, very positive things from many of you about how classes are going. So I hope that continues to be the case. But really, I just want to thank everyone for, for your efforts to help keep the community safe, because, while I know everyone is tired of this, everyone is impatient with this, everyone wishes it was over. I think we recognize that the kinds of mitigation strategies we're using are absolutely critical to where we are at this moment in time. And, Dean Livingston and others will say more about, kind of where we stand in the arc of things. But I think that one of the things that we recognize is that getting used to the idea that it's hard to predict where we will be from one moment to the next, and that just being ready to move with the information we have is really important. We unfortunately don't always know with a certainty what 2 months will look like, what things will look like 2 months from now. And so, really we have to focus on, what makes sense for our community at this moment in time. So that is all I wanted to begin with. Carolyn, do you want me to turn it over to Ben now?
That would be great.
That's right. I'm always just a warm up to Ben, who is always the featured speaker on these occasions. So really, he's got the information that we're looking for.
Thanks, President Byerly. Pleasure to be with you all over the noon hour here today. Yeah, Carolyn, I think, introduced me well. I'm Ben Miller, an epidemiologist. Have worked at the Minnesota Department of Health in the past as an epidemiologist on a variety of outbreaks going back to the original SARS. That seems like a while back, and many things in between. Now I work for a public health consulting company, the Atchison Group, and I've been engaged with the college and several other liberal arts colleges in the U.S., really kind of formulating their COVID response since back to the summer of 2020. And I think, as President Byerly mentioned, things have certainly changed over that time frame, in both the way that we think about risk mitigation, and also just the tools that we have at our disposal to manage risk and risk of infection on campus. So, we've had a document in place and planning structures in place, working with Carleton all the way back to that time, but really have continued to refine those as the science around COVID has changed. Obviously, Omicron's a much more transmissible variant, but and able to break through some of our vaccines. But we've formulated policies around vaccination and boosters and masking and many other aspects of campus life based on the science that was available at the time. And we continue to work and update that with the core team that really has done incredible work at Carleton to pull all of this together. I think one of the good things, the things that gives me comfort, is that going back even a year ago, some of the threshold measures that we set and never really exceeded back in the spring of 2021 came into use and were valuable as we looked at planning for Omicron in terms of when would we do surveillance testing, and when might contact tracing resources need to be focused if we see a number of cases on campus. And just putting a lot of those measures in place, I think we have been successful looking at the numbers in terms of positivity rates across the community so far. I think that the numbers have been actually fairly encouraging when you compare, the rate of illness on Carleton's campus compared to the broader community. So while we've seen a surge in Rice County and Minnesota across the US, we haven't really seen that in the data so far on campus. And I think that speaks to the power of, a widely and highly vaccinated and boosted population, as well as ready access to testing and just a lot of the tried and true epidemiologic things that we can do in terms of contact tracing and isolation and quarantine where it's appropriate. So by using the tools that we know that work, we've been able to keep case rates relatively low compared to sort of the broader public since students have come back to campus. And it was a challenging time, I think, to come back to campus right after the holidays. Had a lot of people traveling from all different parts of the country, and in some cases parts of the world, with a lot of social exposures that happened over the holidays. And that really was why we saw some higher positivity rates in those first few weeks back on campus. But things, and I'm just looking at the data this morning, things continue to look good and see some decreasing overall community positivity rates. So with that, I will turn it back to Carolyn if you want to.
There
are questions.
There are some questions that we have already received, Ben and President Byerly. But Ben, I want to stay here with you just for a little bit and say, what are you hearing and seeing as far as if we have peaked in the state of Minnesota as far as Omicron transmission?
Yeah, I was looking at that data yesterday, both kind of the CDC's ensemble models, where they take data from a variety of models, and then the Mayo Clinic's done some forecasting models as well. And almost regardless of which model you look at, we're either at peak right now or we'll be peaking within the next several days. And the encouraging news is that when we look at other parts of the country, like New York City and New York State, some of the states in the Northeast, they've seen this rapid rise in cases, but a rapid decrease in cases as well. So I think we'll look to see over the next 2 to 3 weeks, rapid decline in community case rates, and that's going to be mirrored, I think, in terms of what we see within the Carleton community and population as well. No, as much as the mitigation measures that are put in place, no college and no community is completely sealed off from the surrounding community. People obviously have interact with others off campus, if that's students or faculty or staff. And so when we do see those case rates come down, I think, we'll certainly see a similar decrease in positivity rates on campus over that same time frame.
Thank you so much. President Byerly, this is a question for you in the sense of what do you think about remote learning? And should we be doing remote learning at this point, more of it as an institution? Your overall thoughts?
Sure. Some of you might have seen the memo that I sent out on Friday, recognizing that, long memos on a Friday afternoon might not have been the highlight of your weekend. Yeah, I'm not sure if everyone saw it, but in that I commented a little bit on sort of how we've been thinking about remote learning at this moment in time at Carleton. One of the things that I think we recognize is that we've learned a lot about how remote learning can help us in this crisis. We could not have maintained our academic program without it. And certainly at this moment in time, some faculty are using remote learning to accommodate either class absences on the part of multiple students, or in some cases a need on their own part to isolate or to reduce their social exposure, for their own personal health. But I think that one of the things that we also recognize is that the impact over time, of not having the kind of classroom environment and the kind of classroom interaction that characterizes a Carleton education, also has a cost, is difficult, makes it harder to maintain not only just those social connections, but also makes learning harder, because so much of what we do in the classroom depends on dialogue and back and forth. It's just, as we all know, much harder on Zoom. And so it's always been one of our goals to reduce our reliance on remote learning and really turn to that as kind of a last resort. And so, in thinking about the model, the decision matrix that Ben referenced earlier, and the fact that, we thought over time about what steps we would get to, we really think of that as the very last lever that we would pull, and, something that we would utilize if we had to, but we would have to get to a pretty substantial area of feeling that, feeling that we had no alternative before we would move in that direction. Circumstances might require it at some point. We can't predict the future, and we hope that we're moving in a positive direction. You can never guarantee that, but I think that that even though in the moment at any given time, one class being remote can be very helpful, because we're trying to to accommodate a lot of circumstances. Over time, the impact of having most people alone in their rooms trying to learn material together is just not the same as being in a classroom. And so when we look across the institution, it's my job to look kind of institutionally and over time. And so I think over time we want, primarily to be studying in person.
Yeah, thank you so much. It seems like we're getting a couple of questions about our decision-making framework, in particular regarding the dining halls, that when we were having this surge of cases, why do we leave them open? And so Ben, I'll point to you a little bit to share your sort of background here, and then I'll weigh in as well from a different perspective as well.
Yeah, that's a great question, and it's something that I know we looked at, or I've talked with the core team a lot about. So where are areas that represent transmission risk, especially with a new variant like Omicron, which we know is more transmissible. I know grab and go options were made available in part to sort of de-densify those spaces, but when we tiered sort of the risk in different spaces, dining halls still didn't rise to the level of risk of exposure and more social settings where people are unmasked and smaller indoor settings. Most of the dining halls are fairly large spaces, and we did do a pretty in-depth analysis of those spaces using an air handling model that was developed at MIT to look at what are safe capacities, and that model allows you to adjust things like infectivity. So if there's a new variant that comes out that's more infectious, we could look at that and see if there was potential risk to folks if they were dining for an extended period of time in those spaces. So we've looked at the data, we've looked at the air handling in those spaces, and felt that that those spaces still didn't constitute necessarily a transmission risk the same way that we were concerned about other settings. And I think that's been borne out. I'll just go back to the data again. One of the important data sets or pieces that we look at are the number of people that test positive out of those who are symptomatic. So we have seen that sort of symptomatic test positive rate decreasing week over week. So when people were first back on campus, that symptomatic test positive rate was about 5.6%. The week after it was about 4.5%. And this last week is about 2.7%. So that's a good measure of, are we seeing a decrease just in terms of symptomatic positivity within the community overall? And I think the short answer to that is yes, and that does support the fact that, or that it shows us that a lot of the mitigation measures that we've put in place, I think, are effective, and we are seeing that overall community positivity rate coming down week over week as well.
Yeah, and I'll weigh in a little bit. And Ben, this is really helpful. You know, we also thought as well when it came to the dining hall, we did remove some tables and chairs to provide, you know, that greater density in the dining halls. So we did do that in some of the areas, but thought that really emphasizing, particularly those folks who had concerns about in-room dining, emphasizing the green to go was a good option. We were concerned about sort of folks coalescing in other areas on campus that were not as ventilated as the dining. And so that was whether it was a lounge or, you know, having 8 or 9 people in a room, whatever the case may be, that was also a concern. The other piece too, and we want to be thoughtful about this when we say closing the dining halls and everything to go, that also creates some additional strains on our staffing. And as most of you know, that this is an area, particularly in the state and across the country, where there have been some staffing challenges. And we wanted to be extremely cognizant of that as well. We got a couple of questions in here as far as how long are we going to require masking? And I will take a stab at that one, and then Ben or the president will ask you to weigh in as well. I think it's a wait and see approach here. This week is testing across the board for everyone on campus. We'll see what our numbers look like this week, and then dependent upon that positivity rate, we will make some additional sort of recommendations, guidance as far as masking and other things on campus. I will say that masking is one of those things that is a true mitigation strategy that has been tested to be really helpful at reducing the transmission. And so, Ben, you want to weigh in here on the masking piece?
Yeah, and I think we really are going to go back and look at the action levels that, you know, we've defined early on, and we followed that framework this last fall, you know, in terms of some of the initial baseline testing, and then what we were seeing in subsequent weeks with some random surveillance testing. And in fact, with the Delta variant, we didn't find, and Carolyn can correct me if I'm wrong, but I don't think we found a single positive through the randomized surveillance testing last fall, which really did match the kind of community infection rate that we were seeing. And so based on that approach, you know, the college felt, and I felt, that it was safe and appropriate to move to a mask optional environment. You know, I think we would look at the data in the same way, you know, as Omicron subsides. I mean, if we're fortunate, what will happen is, you know, we'll actually go to fairly low case rates because there's a lot of vaccine induced and infection induced immunity just within the broader community, as well as on campus. You know, people that have been vaccinated and infected are frankly going to have a lot of, you know, residual immunity for an extended period of time. You know, what we see too when we compare a campus like Carleton to some campuses in the Northeast that were requiring masking and doing testing throughout all of fall semester. Some campuses were testing everyone twice a week. The overall campus infection rate at the end of the semester were very identical between Carleton and some of the schools in the Northeast. So even though they were doing this additional testing and had masking in place, the end number of infections from a population standpoint or percentage standpoint ended up being about the same. So right around 1.5% to 2%. And the reason for that is largely infections were driven by social settings or within households. And so we weren't seeing a lot of infection in common spaces like classrooms or in other places on campus. And so, I think we'll look at the data. If we see evidence that there's a greater risk of that, then we would adjust the planning accordingly. But we certainly expect to see case rates decrease and continue to decrease over the coming weeks, and make a decision based on that data.
Yeah, and we want to also be thoughtful of those folks who are, immunocompromised, and it's their preference to continue to wear a mask. I will say that when we relaxed the mask mandate last year, last term, we probably still had half of our community who were still masked up. I continue to mask because I had, kids at home who weren't eligible for a vaccine. And so a variety of reasons people continue to wear masks. And so, again, we'll continue to see what the numbers will look like as far as positivity rate before we make some decisions there. There's another question in here about why aren't we requiring a KN95 or KN94 mask for everyone in the community? And really, we've made it available for everyone who needs a mask, and we still have some here in my suite, in the Dean of Students Office suite. We've had some challenges in sourcing masks, frankly. The supply chain for masks across the country are pretty low. I think right now, unless you're the federal government, there's some shortage. But so we haven't required something that we're not going to require something that we can't provide one for everybody in the community right now. But we are making them available for everyone who wants one. And so please feel free to stop by Dean of Students Office suite to pick up a mask. But that's why we've have not required one, is because of the sourcing challenges that are associated with it. We got a question about what's our end goal? Is our end goal no cases, minimal cases? What's our plan, or what's our goal in order for us to say that we are completely back to normal? And so that's a very interesting question. I will say that we don't have any illusions about having 0 cases on campus. We know that we are going to have cases, and my perspective is we are trying to reduce the transmission of the virus on campus. President Byerly, Ben, you want to weigh in here as well?
Maybe I would just add a couple of things to that. Even the phrase "back to normal" we recognize is kind of a misnomer. What normal will never be what it was before this, and I think it'll be a long time before the effects of this experience go away. Even when we feel very satisfied with where we are in terms of the actual transmission of virus. We certainly don't have a particular number in mind where we say this is an acceptable level, this is not an acceptable level. We will always strive to do the best we can. At the same time that we're trying to balance the protective measures we're taking against, what we spoke of earlier, which is the desire to offer the kind of education, that students come to Carleton to get. And so in balancing those things, I think we imagine getting to a kind of steady state where we have, reduced transmission to whatever level seems absolutely the best possible. Whether that's 0 or not, I don't know enough. And I'll turn to Ben in a moment to say whether he thinks that's a level that we'll ever get to. I certainly imagine us getting to a stage where most of what we do proceeds in much the way that we would wish it would, without as many layers of intervention. But it might be that some mitigations or interventions will last a long time. And I think it's also true that the psychological impact of this, I think, is going to be with us even when we're not talking about case rates. I think that from my perspective, one of the things that's most salient and most concerning is that this has been an anxious and stressful time for everyone, for students, for faculty, for staff. And I don't think we'll bounce back from that immediately, without thinking carefully about, how we care for the community and how we, try and, manage our own levels of energy and our own enthusiasm for the tasks that brought us here. And so I try not to use the phrase back to normal, because I think that's setting the bar in a place that we'll never really be able to see again. But I think on the other hand, I see where we're moving as a very positive direction. I feel, very optimistic about the idea that, we will continue to improve our ability to reduce the number of interventions needed. And again, if you think of where we were a year or so ago, the idea that we're able to, be on campus together, have the majority of our classes in person, have most athletics and other activities operating in much the way we would wish, have large numbers of activities able to proceed. That's very different from a time when we couldn't even gather in spaces together. So I think that I feel very positive about where we are, but I would say that the end game is not really something we can define at this point. It's something that we will always be working towards as just the optimal state that the circumstances allow. I don't know, Ben, what you would add to that.
Yeah, I've had several conversations along these lines, just sort of with people in my personal life. So what does it look like? And I think it does. It's important to look through several different public health lenses here, and I think just broad well-being and mental health is certainly one important public health lens that I think we're all going to need to look through, sort of moving forward into when COVID becomes endemic. We're not quite there yet. Obviously, we're seeing these huge surges of infection. We're not in the endemic stage of the pandemic, but we will get there. We're never going to get to zero with COVID, probably not for the next 30 or 40 years, realistically, just sort of looking at other infectious disease models. And so then I think the question is, the other public health lens of infectious disease, how do we manage this in a way that creates the least amount of disruptions to what our goals are in terms of being on a college campus and learning and doing everything that represents, and reduce risk at the same time. And I do think in some ways that colleges have really been at the forefront of that thinking. Even it may not have been intentional, but it's just in the way of having to confront that reality maybe sooner than other segments of the public. And so I think some of the frustration around just COVID in general has come from sort of mixed public health messaging. Whereas I think if you look at some of these action level and planning documents that we've put in place and have had in place for a while, they do really provide a roadmap of like, okay, well, if cases get to this level, here's what things will look like. And, that's not going to be forever, and as cases drop back down, here's what things will look like. We'll dial back a lot of those mitigation measures because they won't be needed or necessary. I think the one tricky part is we still don't know kind of where the pandemic is headed. Could there be another variant? Could there be a variant that causes more severe illness, at which point, you recalibrate that risk calculus to some extent. But if we're clear about communicating what those outcomes look like and sort of when those thresholds changes and what those risk mitigation measures look like, I think that does provide some assurance, hopefully, to this community and others if we head in that direction more broadly about what to expect. And I think that's really what people are looking for right now, is that clarity. What can I expect now and in the future? So hopefully we're moving in that direction.
Yeah, sure. And hopefully we're not doing this for 40 years. So please don't.
No, I don't think we're going, just to clarify, I don't think we're going to be, but we're going to have COVID infection, much like we have influenza infections. I mean, I think there's sometimes been a false dichotomy between those two. It's just the flu, and I don't think that's true. I mean, we're dealing with a variant that's 4 times more infectious than the typical flu, but at some point, just sort of from a population immunology standpoint, we do get to a point where enough people have built up enough collective immunity that the severity of illness should be pretty muted, and that we will think about it just as a normal endemic illness, if you will. So I just to clarify that statement.
All right. Sounds good. Let's talk about some of the mitigation strategies. So getting a couple of questions about one card access to all dorms. When will it be restored? We're also getting questions about spectators at sporting events as well. So we've made a few adjustments to the one card access, in particular for those students who are in complex, and providing them some access to be able to get to the dining hall versus having to go outside of Davis or Sevi to get to their dining area. So that part of the one card access has been restored. The other parts, it is dependent upon our positivity rates. What we know is that we had seen some transmission this term and also in previous terms about that sort of unannounced access to spaces. And so as soon as our numbers get a little bit better here, we know the importance of being able to drop in on friends and spend time with each other is a huge part of the community building aspect of Carleton. And so as soon as we look a different direction as far as positivity, that piece will certainly be restored. Updates on allowing spectators, I think that's also a wait and see approach as well. I think particularly for our athletes being able to, who have family members who are close, they really want their parents and families and friends, and you want to be able to attend events as well. And so we will continue to assess that on a weekly basis. For now, we just say if you can tune in to the video, to the live stream, that is really helpful in providing support to our athletes. We got a question here about why are we not testing more? Why are we not testing everybody very much like our peers in the Northeast 2 or 3 times a week to really reduce the transmission? Ben, you want to take that one? I'll add to that one, and the president can weigh in as far as what she's hearing. But what is the efficacy of testing 2 to 3 days a week, like some of our peers up north?
Yeah, that's a great question, and I'll give you a couple different perspectives. First and foremost, I would say in a highly vaccinated, boosted population, the most important testing we can do is to test people with symptoms and test them a couple times. And that's what we've really seen with Omicron, is that, especially with rapid antigen tests, that test sensitivity is still good, but it matters when you test. We do have, I think, somewhat of an advantage in the sense that in a highly vaccinated and boosted population, people are not really likely to be terribly infectious until they have a symptom onset and even after symptom onset. So we have maybe a little bit of a grace period before when somebody's throat might start to feel a little sore or scratchy and they get tested, and when they could actually be infectious to others around them. So we have that benefit, which is a little different than the general public, where we have just complete mixed vaccine status overall. And so when you look at kind of public health recommendations and where they may differ between what the college is doing and what the CDC might recommend, that's one reason. We do know or suspect that there probably is some risk of asymptomatic transmissions of people that never have symptoms, although again, for Omicron, there's not great data on probably how much of transmission, especially in a highly vaccinated and boosted population, is really driven by asymptomatic transmission. So it's not the primary driver of infection within the campus population overall. And we saw that too with Delta, really focusing on symptomatic testing was a good way to approach illness management in terms of population illness management for Delta. That's essentially the approach that we're taking for Omicron as well, to some with some differences, right? We have seen a higher positivity rate, and so there has been surveillance testing. And Carolyn, I believe you said there'd be full campus testing this week. Is that correct?
Yeah, that's right.
And that's using a PCR test, is that right? And so that's another difference too, is that when we talk about testing frequency, that's also driven by test type. So I'll draw a picture with my hands. So somebody's infectious sort of or over a course of time, and that follows not quite a bell-shaped curve. It's shifted to the left a little bit depending on where you're standing, but PCR will detect if somebody is actually infected in a much broader time frame. So if I'm not symptomatic at all and I have just a little bit of virus in my symptom way over the left-hand side of the curve, or if I've passed through my course of illness way over the right-hand side of the curve, that PCR test is very likely to pick that infection up versus an antigen test that's going to just has a much higher threshold of detection, hundreds of times higher. So you need quite a bit more viral load to test positive on an antigen test. And so testing multiple times over the same time period with an antigen test is essentially equivalent to testing once in a week with a PCR test, just because of the sensitivity of detecting infection between those two types of tests. So that's really why in some campuses, and there are places in the Northeast that are testing several times a week with a PCR test. But that doesn't necessarily mean that if you're detecting somebody on a PCR test who's positive, that they are in fact infectious. There's been research that's been done that, if you look at, and this gets way into the sort of PCR testing technology, but cycle thresholds, and if your cycle threshold is greater than 35, you're probably not infectious, and maybe not even if you're greater than 30. And what does that mean? And we don't get that level of analytical data from the testing laboratory that Carleton uses. And by the time we would have it, it's probably not effective in terms of a disease management strategy. So really relying on people to report symptoms and get tested when they have symptoms is probably the best prevention measure in terms of community transmission that we have.
Sure.
Carolyn, maybe I would just jump in and say, having talked to a lot of presidents at other institutions, both in the Northeast, from whence I came, so still have lots of contacts there, as well as folks in the Midwest. One of the things that's important to recognize too is that campuses are very different from each other in terms of their geography and sort of their porousness relative to the surrounding community. Some are a little bit more rural and isolated, and perhaps even more isolated than we are. Others have many more students living in the community, higher population, not living directly on campus, but coming and going. All of those variables play into it. And so in talking with, with other presidents, decisions about things like level of testing often have as much to do with, sort of ambient factors as the positivity rate or, the circumstances on campus, just in terms of the spread of illness. I'd go back to something that Ben said, 20 minutes, half an hour ago, which is that in comparing actual results at the end of term, what we saw was not very different from that of some campuses that had been testing 2 or 3 times a week, which means that was giving them valuable information and peace of mind, but it wasn't necessarily giving them information that made a big difference in the ability to control transmission, that we're catching enough of what is out there to be able to isolate people promptly enough to reduce the rates at a pretty equivalent level. And so that's one of the things that I think gives me confidence that our testing plans have so far served us very well.
Yeah, thank you so much. We got a question here about the dashboard, and in particular, why are we just updating it weekly rather than when the number of cases are reported? And I'll we'll work to answer this question. And really, it's about how do we provide the most clear and accurate information to our community. Weekly reporting allows us to do that. The daily reporting does not. We want to be thoughtful about. It takes some time to get the PCR test results to come back. We get test results that also come from SHAC. We get test results that come from the screening center. So we're getting a variety of test results, and that does take a significant amount of time to be able to update that. And we just really increase our chance of error if we are doing it on a daily basis, whereas on a sort of a weekly scale, we're able to provide the most accurate information. And so that's a part of the reason why we have not done the daily testing. I will say from experience this morning, I was sharing in our Tuesday group meeting about the number of students that were in isolation. At the beginning of the meeting, it was at 21. I'm sorry, 28. By the end of the meeting, it was at 21. And so in real time, how do you sort of account for that change? And so we want to be thoughtful again about providing that accurate information, and we're able to do that better on a weekly reporting versus a daily reporting.
If I can,
yeah,
please.
please.
I was just going to quickly add that it's one of the things that I know, we talk about in the senior administration in terms of patterns of communication and how we can give the best flow of information. It's one of the things that in the two memos that went out Friday, we talked a little bit about, we try and think about when is information helpful, when is it too much. One of the things we do recognize is that as Carolyn mentioned, if you report once a week, you're kind of smoothing out all of the variation that comes day by day and getting a more kind of accurate collective picture. If you watch it day to day, it looks a little bit more like, watching stock prices hour to hour. They go up, they go down, you panic, then you feel better. It's a lot of, it's a more confusing, there's a lot more noise in the data. And so I think I would, reemphasize that it's not only just that it's work to put the information together, but that looking at the 14-day positivity rate where it's, averaged out over a 2-week period really gives you a better sense of what has actually happened in the community during that time without seeing, kind of the small swings that can be affected just by the timing of when test results are released, for example. I'm sorry, Ben, if I stepped on you for a moment there.
No, that's fine. Yeah, and I think that you phrased it well. That's essentially how I look at and analyze that data is, over a week and a 2-week period. Now, that's not to say that if there wasn't some acute event that, the college wouldn't be aware of it and react accordingly. If there were a cluster of cases within a particular dormitory, for example, or associated with a particular event. And I know we've had those discussions. So it isn't that those things are passing unknown. I think, they're just not necessarily reflected in the dashboard in real time. But, the college is taking appropriate action if there were to be a cluster of cases, and they reach out to me and we certainly work through that. But I think, right, you want to look at the data in enough of an aggregate period to really get a good sense of what did this last week look like? What did the last 2 weeks look like? And that is really what's driving, a lot of the planning, the forward planning that's associated with the action threshold document.
Yeah, Bid, we got a question here, and maybe this is pointing folks to any information about what do we know. Is there an article that you could point folks to as far as the long-term effects of COVID? Anything that you're seeing in your scientific journals?
Yeah, I'll make a note. There's a few good articles out there in terms of, long COVID, what percentage of the population might develop that, what are some of the long-term symptoms and some of the challenges treating it. I think, what we don't know yet is what's the association with an Omicron infection in long COVID, especially in those that are vaccinated and boosted. Is there a decreased risk in that population compared to the general population overall? I mean, that research is being looked at and conducted right now. But happy to share what a few good articles. I can send those to you, Carolyn, if you want to send them out after the call.
I'm happy to do that. Hey, another really quick question is, folks who said they've had some challenges on getting, they're identified as close contacts and they're having some challenges of getting tested in the screening center right then and there. Can you sort of talk, Ben, about a philosophy of when do folks who are close contacts, their recommended time? And we're aware of the anxiousness of folks when you immediately learn that you are a close contact. The first thing you want to do is get tested. When is it likely to show up on an antigen test, Ben?
Yeah, that's a good question. What we do know is the incubation period of Omicron is likely shorter than other variants. And so, we've sort of seen the public health guidance around when's the best time to test people move around, right? Over time, it used to be 3 to 5 days, and it was 5 days. And then, we were, recommending testing a couple points in time if somebody is a close contact. And you'll have to remind me what current practice is.
Yeah, 5 to 7.
Yeah. So yeah, testing within that time frame still makes sense from an exposure standpoint. Obviously, if somebody is exposed, and let's say I'm exposed or Carolyn's exposed to me, we'll go that way. Like I test positive on an antigen test. Well, she's not going to be immediately. Well, one, we won't know if she's potentially infected. Two, she's not very likely to test positive on that test, at least probably several days into when she would have enough produced enough virus, and that's not going to start typically until day 4 or 5. So, if you're a close contact, really one of the best things that you can do is just continue to monitor for symptoms. Hopefully you don't develop symptoms, but if you were to just pay attention to symptoms and line up and set up to be tested 24 hours after symptom onset, that's probably one of the best pieces of advice that I have. But otherwise, testing asymptomatic people within that 5 day, right around day 5, is still considered best practice to see if they might be asymptomatically infected.
And also to stay masked up as well.
Correct. Yes. Yeah, absolutely. Yeah. Kind of without saying, but
yeah, I mean, I will say, and Ben sort of shared this earlier, that it's during the sort of weekly, the PCR test, the surveillance testing, where we're picking up the asymptomatic folks, and it's during the screening center where we are identifying those symptomatic folks who have tested positive. I will also say that as we really progress, we are now in week 3, which is really hard to even imagine that we are. Wednesday will be going into week 4 of the term. Some of the things that we're thinking about, some of the things that are on top of mind are continuing to monitor that positivity rate to see which restrictions, if any, that we can relax. We know that there's an interest in relaxing some more than others. And so we want to be thoughtful about being able to relax restrictions. We are also wanting to ensure that we continue to source masks, that we have some available for everyone. We also want to pay particular attention to continuing to encouraging those folks who are symptomatic to get tested at the screening center. What may be perceived as a cold or or the sniffles might be COVID, and so we want to be able to encourage people to take advantage of that. We also are thinking about things like spring break and spring term and all of those things as well. But we just need a little bit of more time to get through these upcoming weeks. Henry, go ahead and put your question in the chat feature for me, okay? Ben, anything that you'd like to share as far as things that we should expect over the upcoming weeks?
Yeah, I know. I mean, I would expect to see both symptomatic illness and just general positivity to continue to decrease. I mean, the community's been back on campus now for, as you pointed out, 3 weeks, and we'll continue to see cases, but I do expect that the rate at which we identify people who are positives to go down, just like we'll see those rates decrease in the community. So, I think we're definitely headed in the right direction and headed to a better place. And I certainly look forward to hopefully being able to go back to where we were this fall in terms of just fewer mitigation measures in place. I do think that's a distinct possibility here in the not too distant future.
President Byerly, what are you anticipating over the next couple of weeks, looking forward to?
Well, I'm listening as eagerly as anyone else to Ben's prognostications. We all hope to see things continue to move in that direction. And I think, as we get into the rhythms of the term proceeding, it is important to remember that the start of the term is really the most risky period, with everyone reconvening after a time away. I think that we certainly hope that as the case counts decline and fewer students are in isolation. Already what you shared earlier, Carolyn, about the smaller number of students in isolation is encouraging. That means less disruption to classes. That means fewer classes, need to be offered remotely. That means, potentially, relaxing some of the mitigations having to do with events and event sizes. All of these things are kind of layers that can be wound and unwound. And, I think as things improve, we'll continue to lift those things. And so I certainly hope and expect that, before we get to the end of the term, we will have restored a bit of balance and gotten a little closer to where we were in the fall, where I think we felt that the, optional masking and the lighter mitigation strategies were working well at that point. And as Dean Livingston said, already conversations are starting about spring break and the beginning of spring term. A lot will depend on how things go in the next couple of weeks, but we certainly certainly bear in mind that those are also times of transition, and basically any moment of transition is a moment to be cautious as a community.
Sure, thank you so much. And it looks like Henry's question is really around sort of something that we discussed earlier was, and he's had some really good conversations with Randy Johnson about the increase, what we anticipate as an increase in the KN95 mask. And as we, for now, we'll continue to make those available. And I think we will see where we are as far as our positivity rates, as far as if we will actually do a mandate of the KN95s. But for now, we are saying we have the KN95s available. We also have the cloth mask, but remember, with the cloth mask, you have to double mask. But we have more than enough KN95s for folks to pick some up, but we just don't have one for everyone right now, to the point of where we would require them. And Henry also wanted to remind folks, even in the residence halls, when you think you're by yourself, just to please mask up. And so thanks for that friendly reminder. We will do this again next week. For those, if there's a need to do it next week, we'll do this again. We will make this recording also available to the larger community. And if there are any questions at all that you might have, please do send them along, or if there are questions that we were not able to answer for you. I think we got about 5 minutes left. And so unless there's some burning questions, we should feel free to give you back 5 minutes of your day.
Thanks for coming, everyone. Have a great afternoon.
All right, thank you as well.
Thanks.